All right. Well, there's quite a few of you already joining. Thanks for those of you who are joining us for this live, and welcome to anyone who also comes on and just watches the recording. You guys are almost done with the semester. Just finals week to go. It seems like it's gone by really fast to me. I don't know about you guys, but yeah. Of course, yeah, a couple of weeks more of clinical too. Yes. Okay, so we'll just dive right into this. Is Carolyn on with me yet? Carolyn will be getting on shortly, so I will go ahead and get started. We'll just go roughly in the order that the units are. So we'll start with family, and let's see here. The print on my screen is really small, so in order to see it, I'm going to have to look on another screen. So if it looks like I'm not looking at the camera, that is why. So for family, just pay attention to that. Basically, what I've got listed here are the on this sheet, this little sheet that I've got uploaded here is a more expanded form of the study guide that we sent you. So I'm not going to give you a copy of this document that I've got on the slide here. If you want to review it more, you can review the video recording of this, or just take a look at the study guide, which or better yet, you could bring up the study guide and just kind of make notes along the way, and there you'll have your very concise study guide to review for the final. Okay, so under family, unit 1, just be aware that family is bonding is enhanced by commitment and strong attachment. And the healthiest type of boundary for families is semi-permeable. If you remember, there's also open and closed boundaries, but the healthiest type is semi-permeable because they let appropriate influences in, and they retain a healthy respect for privacy, and the family members feel responsible to care for all members. And then also remember that family is an integral part of the interdisciplinary team. We do need to include family members when we're making decisions and doing patient teaching and that. And yeah. Oh, and looks like Carolyn is jumping on just in time to go over unit 2, which is geriatrics. So are you ready to take over with geriatrics, Carolyn? Oh. Hi, Carolyn. Can you hear me? Can you guys hear me? Okay. Well, it looks like Carolyn might need to get her the speaker working or something. So I'll just move on with genetics while she's bringing her things up. Okay. So let's see, for genetics, we just, oh, okay. So with genetics, just be aware of the different chromosomal abnormalities, such as the monosomies, trisomies. So the aneuploidies are the monosomy where you only have one chromosome, and when there should be two, and trisomies when you have an extra chromosome. Good examples of trisomies are something like Down syndrome, which is trisomy 21. And then there's also things like the autosomal dominant disorders, which is Huntington's disease. All right. Oh, I can hear you now, Carolyn.
Yeah.
And I'll just finish up with genetics. Yeah, I guess I just finished up with it. So we're ready for you to start in with geriatrics.
Geriatrics?
Uh-huh.
Okay, so you got the list here. It's there, so let's look on the geriatrics.
Do you want me to do a screen? Oh, I guess I didn't get your portion of the list. You have mine, but I don't have yours. So if you want to do a screen share.
Oh, crap. I don't know where I put it.
Well, you can just talk through it then, I guess.
Do you guys have the list that I sent you on Canvas? Megan says yes. Is everybody out to lunch? Okay. Okay, so on the list, talks about dementia. So go and look at that chart in your PowerPoints that tells you the difference between delirium, dementia, and depression. Okay, because they'll have those three things there again, and you'll have to determine whether it's a dementia or whether it's a delirium or whether it's a depression. Okay, so that go to that chart, make sure you're aware of what is on that chart. There's also another part down there that says you got to know the difference between delirium and dementia. And how do we know the difference between delirium and dementia? What question do you ask? Onset, right. So delirium is acute and happens really fast. Like they've been just fine. They've a lot of times the family will bring them in because grandma is like off her rocker, but she ends up having an infection or something else that's causing the delirium, and then it's acute. She was never demented beforehand. Or you can have someone who has dementia but is like all of a sudden goes really bad and a lot worse than they've ever been. That would be a delirium on top of the dementia. But anyway, so if it's acute, it's going to be delirium. If it's long acting, it's going to be dementia. Okay, the most prevalent type of dementia that we talked about was what? That happens to older people most often. What type? Alzheimer's, right. So be aware of the Alzheimer's. Also, like if you are working with safety measures for older people, say that you have someone, and a lot of people remember polypharmacy, that the older population takes 20% of all the medicines made. So they take a lot of different medicines because of chronic illnesses and everything else. So what you're going to do is grandma has 25 million pills. So how are you going to help her, be safe with the pills? Remember the film we watched? You're going to think way back where the little lady took her pills and then she kept doing stuff. The bottles were just sitting there. And then she's sitting there about an hour or two later and going, did I ever take my pills? So think about what could you do to prevent that from happening so that they don't take them again? What would you do? What kind of, right off the top of your head, what could you think? A pill box, right? Okay, or I know that Amazon has that thing where all the pills for 8 o'clock are in one bag, and all the pills for this time are in one bag, and you can get the pharmacy, certain pharmacies to do that too, as opposed to a pill box. But a pill box will work so that they know, oh, it's empty. I did take them. Okay, so also think about some of those, the next thing I think they're talking about is caregiver burnout. What is actually keeping, if you have a couple and one of them has Alzheimer's or some kind of a dementia and can't take care of themselves, and the other person is the caregiver or whoever is there, What happens if that caregiver can't do it? Where does the patient, or where does the person with the problem go? What's going to happen to them? Nobody has an idea? Are they just going to stay at home? Say that their wife has to go get their knee fixed and is going to be in the hospital. Yeah, they're going to come back to some kind of a care facility, or they're going to have to get somebody else to come in and take their place. That is the reason why we look for caregiver burnout, because we want to make sure that the caregiver is still okay to continue on with their job, in essence. And that's why we do respite. That's why we give them breaks. So that's why we look and watch for them, even though they may not be that person or that patient that is on the chart. We still have to look at the family member who's doing all the care. Are they burning out? Do they need some relief? And that's where we step in. So that's really important. Okay, so also some of the terms like reminiscence. So if reminiscence, what is reminiscence for older people? What is it? How do you do this? If you're going to use reminiscence on an older person, what do you have them do? Think about that. Yeah, they reflect back on life. They think back. That's one of the things that Erikson talked about. If you look at the theorists, so remember, there's two theorists that go with the older people. Okay, you had, I believe, Havikhurst, and you had Erikson. And Erikson, that's when they're going to evaluate whether or not their life had meaning. They're going to look back and see what they've done. And they're going to have, my mind just went blank. Despair is one, or gratitude, the happiness, whatever, that word that Erikson uses for that area, that group. Okay, so be aware of that. Integrity, yes, thank you very much, Taylor. Okay, so those are pretty much kind of the things that are going to be on the geriatrics part. So the other part, when you get into death and dying, okay, you need to go and look on your PowerPoints, on your stuff, and see what are the things that we know that person is dying. So impending death. What is their blood pressure going to do? What is their skin going to do? Their kidney shut down, all those kinds of different things that happen. So be aware of that, of exactly, because I think you're going to have to pick that out as how do I know this person is on the verge of passing. Also, if you're dealing with an older person or a younger person, whoever's dying, how do you incorporate dignity in their death? How do you help them? What would you guys think? How if you were dying, what would you want to be helped with? Okay, what would you want? Do you want other people making your decisions? Do you want do you want to be included? What do you want? Do you want to be able to call the shots or not call the shots? So one of the things that we really need to do is to make sure that we include them in what's going on. Now, if they would rather have the doctor make all the decisions, that's up to them. But again, keep going through it, making sure that they don't change their mind and they want to be included. So they're still going to be included because you're going to ask them what they want. Okay, there's some therapeutic communications. Look at how you would talk to somebody who is grieving, or a family member, or any of those kinds of things. Be aware what the normal grieving process is. Remember, I told you that when people die, everything isn't all hunky-dory once the funeral's over, especially the closer that person was to that individual. That's a lot of times, especially with partners. Woo! I just took myself out of the picture. Especially with partners, a lot of times what happens is that it's a good year. Now, granted, how you feel the day that they die and how you feel a year later is going to be less, and it should slowly go less. Okay. And, but you've got to give them a sufficient amount of time. You can't, if things haven't happened in a week, and they're still having problems with grief and showing grief signs and symptoms and things like that, you can't just pull them out of it. You've got to give them some time, depending on how close they were to that situation. So be aware of what is normal grieving procedures and what is abnormal, okay? So that you can differentiate between those two. And I think, let me see what I've got here. Yeah, I think that's all on the death and dying. So it's your turn, and now you're on newborn, right?
I'm getting there. First, we do, well, yeah, newborn screening is listed there, but that is part of the conception and fetal growth and development unit. So I think I'm not going to try to keep track of the numbers, but I think it's like,
okay, whatever number it is, the next one that comes up.
Yes. Okay, so that is part of the newborn screening that we do is just checking for if they have a metabolic disorder, which means that if they have a metabolic disorder, then if they eat something that they can't digest properly, then it would be like a toxin in their system, and it can cause damage. And the most common one is the phenylketonuria, which is PKU, and that's often this metabolic screening is called the PKU test because that was the first one they started screening for. But anyway, if they detect that the newborn has phenylketonuria, then they withhold anything in the diet that would cause the phenylketone to elevate, and so then it can help to prevent them from having cognitive disorders or other physical disorders as a result of eating something that they can't digest. So that's why they do the metabolic screening, is for early detection of these disorders so that it can prevent a lifetime of harmful consequences. And then for genetic counseling, we just make sure that, oh, sorry, this is still part of the genetics unit. I just stopped in the middle of it when Carolyn got on. But anyway, so the other part of the last thing we'll talk about under genetics is the nurse's role in genetics. And that is usually it's the nurse who, while taking a family history or health history, we detect when they are at risk for genetic disorders and may call it to the attention to their physician or encourage them to consider genetic counseling. So remember that genetic counseling continues. It starts with us detecting that they are at risk, and it continues through testing, and then there's a follow-up to help interpret the testing results, but that is usually done by a geneticist. Okay, so now the next unit is conception and fetal growth. And so I kind of, before I flip the slide, does anybody remember, type in the chat box, which hormone we assess for as part of the pregnancy test? All right, very good. So that's HCG is human chorionic gonadotropin, and it is only produced when the woman is pregnant, either pregnant or if she has the choriocarcinoma, which is follows a molar pregnancy. And that's what we look for in a pregnancy test. However, it's not a positive, it's a probable. If she has an positive HCG, it's just a probable sign of pregnancy because it can also be caused by the choriocarcinoma. So remember that estrogen helps to maintain the decidua. It increases over pregnancy, but gradually, and it's the same with estrogen. So since those hormones of pregnancy increase more gradually, they don't tell us whether or not she's pregnant quite. So HCG is the one there. Okay, remember teratogens, which are substances that can cause birth defects. And that's because they generally cross the placenta. And the severity is, and I kind of have it on the sheet there, but if, so I can't quiz you quite as well as Carolyn was just doing because I've got the answers right on the board, but just to help cement it in your brain, go ahead and type in the chat box, what is the time during, when is the time during pregnancy when the developing infant is most at risk for teratogens? Okay, yes, both of those are right. The embryonic stage, which is also 3 to 8 weeks. So the embryonic stage lasts from 3 to 8 weeks. That's post fertilization. So that's how old it's not quite a fetus yet, so we can't call it a fetus, but yeah, the embryo is. All right, so the embryonic stage is when they're at greatest risk for the greatest damage. And just remember the teratogenic agents are, they can be like infections or environmental exposure, things like that. Oh, and yeah, medications, things. Yeah, so let's move on to antepartum. So what's the most, oops, before I flip the slide, let's go back. What is the most important lab that you would want to know of a pregnant woman? So any and all of them would be important, but what is the very most important lab that you would want to know if you are caring for a pregnant woman? So, blood pressure, that is a great assessment finding, but I'm referring specifically to lab work, something that you would need to send down to the lab. Glucose is important. You need to know that to see if they are hypoglycemic or at risk for gestational diabetes farther along in the pregnancy. But that's not the very most important. Yes, Leslie, it's the Rh factor, because if they are Rh negative, it's a very important safety measure to provide the woman with RhoGAM, because remember, she does get it during the pregnancy. She'd get it at 28 weeks gestation if she's Rh negative, and that is to help prevent the fetus from developing, that's to prevent her from developing Rh isoimmunization, which could cause significant harm to the subsequent fetus. So, all right, very good. So that's why I've got Rh emboldened, is because that's the very most important one. Okay, so remember that progesterone is kind of this, think of it as the spa hormone, because it's what promotes the body to slow things down and just relax and have it and cook a baby. Just the body needs to make some adaptations in order to send more energy and nutrients to the developing fetus and embryo. So in order to do that, everything else in the woman's body typically slows down and relaxes. So, for example, her peripheral vascular resistance decreases, her GI motility slows quite a bit, which puts her at higher risk for constipation and also, we'll just leave it at that. So you just see what's listed there under progesterone, the things, the major changes that progesterone causes on the body, as well as promoting the pregnancy. And so these are the effects that the hormone has on the woman listed there. Okay, let's talk next about preeclampsia. And okay, so I'm just frustrated because I fixed that so that the preeclampsia would be its own heading and not look like it's falling under progesterone, but for some reason it didn't show up that way. Anyway, so preeclampsia, this is where we're going to talk about the blood pressure that Chelsea mentioned in the chat box. So what is this, if a woman has an elevated blood pressure and she's pregnant and it first happened, she first got her elevated blood pressure after 20 weeks, then we call that pregnancy-induced hypertension. The very first degree of the disease is gestational hypertension. At what point do we consider it preeclampsia? What needs to be present along with the elevated blood pressure for it to be considered preeclampsia? That's right, protein in the urine. Perfect. Okay, so, and then the next stage of the disease progression is eclampsia, which is where she's actually having a seizure. Yes, so whether there's protein in the urine or not is the difference between gestational hypertension and preeclampsia. And the difference between preeclampsia and eclampsia is with eclampsia, she's having seizures or in a coma. So, but there are some symptoms that develop between the developing protein in the urine and the seizures. So what I've got listed here are the signs of disease progression. If you can see that having edema of the face and hands, rapid weight gain, which means that she's retaining fluid. And then what I've got emboldened is probably one of the most important, and yes, I would say the most important symptom that indicates the disease is progressing, and that is hyperactive reflexes. That means that the central nervous system is becoming irritable, and the next step past that is going to be a seizure. So we really want to know what her baseline is for her reflexes. So if we've got a preeclamptic patient, we want to check her reflexes to see what her baseline, and we want to watch them for any indication of hyperreflexia. Also, a severe headache and visual disturbances indicate that there's some CNS involvement. And then epigastric pain indicates that the liver is having problems, and that's related to the HELLP syndrome. Okay, which is hemolysis, elevated liver enzymes, and low platelets. But I won't say anything more about that. That's all we need to review for preeclampsia. Let's talk now about some hemorrhagic disorders of pregnancy, which are ectopic. This ectopic pregnancy is when the pregnancy does not progress to the uterus. So the fertilized egg is either in the fallopian tube, or sometimes it goes outside of the fallopian tube into the pelvic cavity, but like 90% of the time it's in the fallopian tube. So we oftentimes just call it a tubal pregnancy. And what causes that is what causes the ectopic pregnancy is often scar tissue of the fallopian tube, and that's related to something like pelvic inflammatory disease or possibly just some congenital malformation of the tubes. The biggest concern with ectopic pregnancy that we worry about most is hemorrhage, because it can cause the tube to rupture, and then she'd be hemorrhaging into the pelvic cavity. So we watch for signs of hemorrhage, which are, again, I've got it listed here, but just to help you to remember it better, go ahead and type in the chat box the signs and symptoms that you would watch for hemorrhage. You might see clots. When we're talking postpartum, you're always going to see clots. With ectopic, sometimes the bleeding is internal, so you may or may not see external bleeding. So what else would you see? Yes, Emma's got it listed. Increased heart rate, decreased blood pressure. You might see abdominal distension. Yes, that is a possibility, but what you for sure will see is the decreased blood pressure and the increased heart rate. Again, because the bleeding might be internal. Let's see. Hey, what's the difference between placenta previa and placenta abruption? Which one is painless? Placenta previa or placenta abruption? Good. Right. The previa is not painful because it's caused by the placenta just being located on or very near the cervix. So just it doesn't require any contractions or anything like that to cause the bleeding to happen. Whereas abruption is the one that is painful because, yeah, and Brooke, you're right. Abruption just sounds more painful, doesn't it, than previa. So abruption is when the placenta tears away from the uterine wall, and that causes tetanic contractions. So when there is a placenta previa, if a woman comes into the labor and delivery unit and she's bleeding, having painless vaginal bleeding, we're always going to suspect placenta previa. So why would we not want to do a vaginal exam if a woman has placenta previa? Go ahead and put that in the chat box. Why would you not do a vaginal exam if a woman has placenta previa? Exactly. You could, just the digital exam could disrupt the placenta and cause a hemorrhage. Okay, so the next one we're going to talk about is labor and delivery. So do you guys remember, put in the chat box, what is the sign that a woman has started the second stage of labor? This was actually in your OB Sim prep sheet, so hopefully everybody remembers this. What indicates the woman has entered the second stage of labor? Right, it's the pushing stage. So when does she get to start pushing? Yes, dilation of 10. So, and that's complete dilation. And also oh my goodness. Sorry. Okay, so just review what the stages and phases of labor are. And then let's see, the fetal head, remember the fetal head must be engaged before the membranes are ruptured. Otherwise, there's a risk of prolapsed umbilical cord. If the membranes rupture before that head is engaged, the cord can slip between the head and the pelvis, and then it can get too much pressure on it and to stop the fetal circulation. So when the membranes are ruptured, the nurse will, the most important thing for the nurse to do when the membranes are ruptured are, number one, determine that the fetus is still safe. So we observe for that. How do we know? Again, I've got it there. But how do we know that the fetus is safe? Is we look at the fetal heart rate. So as long as the fetal heart rate looks good, then we know that the fetus is tolerating the change in environment. And then we also want to note the color of the amniotic fluid. Because why? In the chat box, why do we care about the color of the amniotic fluid? Right. It should be clear. So if it's not clear, if it's light yellow or green, then there's meconium. Exactly. Okay. And if a woman has had a previous C-section and she wants to deliver vaginally, we watch her carefully because she is an increased risk for uterine rupture, as you see here. And that is the highest risk of a uterine rupture, is a woman who's delivering by VBAC or vaginal birth after cesarean. Okay, when we're looking at the periodic changes of the fetal heart rate, that means accelerations or decelerations. We're going, just remember this acronym, BIL, CHOP, MINE. Remember that if it's a variable deceleration, though it's variable because it can happen at any point before, during, or after a contraction, it is caused by cord compression, and it's relieved by changing her position. MOVE, so the M stands for MOVE. Early decelerations are caused by head compression, and the nursing action is I initiate secondary measures, which basically means we just want to check her cervix to see if she's if the head is descended significantly. A is our accelerations, and these are okay. They're actually a good sign. So the nursing action is N. We don't need to do anything. We do nothing because it's good. Everything's good. And then L, late decelerations are caused by placental insufficiency, and E is emergency delivery if they're persistent. Okay, now we're ready for Carolyn to take over with postpartum.
Okay, I'm getting there. Okay, so on postpartum, make sure you know what is normal and abnormal vital signs. Remember what happened. You heard Natasha talking about what the hormones do. So a lot of our patients will have lower blood pressures, which is normal. Everything's going to relax, those kinds of things. Remember, too, it's not unusual to have a postpartum mom for the first 24 hours to run a temperature. Okay, we still have to call if it's what magic number? Can you guys remember what the magic number is we have to call the physicians for a temperature? Nobody's guessing. 100 point what? Not 104, but 100.4. Chelsea's pretty close. Okay, so also, it's not unusual to have the pulse be down, lower, or normal. And respirations are usually normal. Okay, so if we have blood pressures that are up, can you remember how high they have to be up systolically and how high they have to be up diastolically, not together, either or, to say that maybe we've got some postpartum hypertension going on? How much diastolically? That's the top number. You're watching their blood pressure. You're looking at it, and all of a sudden you get a higher blood pressure. How much are you going to be nervous about if it's up high? How high? Anybody think? Okay, so let's see if Chelsea's got it. I see her typing. Can't go on 140 because pregnant women and postpartum women still have those hormones in them, and their blood pressures run low. Okay, so all they have to be is if they're no, we're not going to go on a number. So take on what they're normally running. If they go up 20 milligrams on the systolic or 10 milligrams on the diastolic, it changes and it starts to be consistent, then we're going to think that those people possibly have some postpartum hypertension. Okay, so 20 on the top and 10 on the bottom from their normal baseline. Okay, does that help? Also, make sure you're very aware of what involution of the uterus is. What does that entail? Where is that uterus going to be? When is it okay? Is there a certain time that it has to be at the umbilicus or above, or, and if it's not where it's supposed to be and it's someplace else, what does it indicate? It's the same kind of a thing. If I have a woman and it's 2 finger breaths above the umbilicus, this is the first day she's just had the baby, and it's over to the side, what are you going to think right off? What's the problem? She's got a full bladder, most likely, right? Right. Now, if she has a full bladder, what's that going to cause her to do? Hemorrhage, right, because your uterus can't clamp down. So make sure you know what the loci is supposed to be doing, where the uterus should be, and when it should be there. So at 4 days postpartum, where is it supposed to be? So what location on the abdomen, when you feel it, is it supposed to be? Four finger breaths, right. Okay. And how is it supposed to feel? Firm, right. If it's boggy, what are we thinking? And what does boggy mean? Yeah, we're going to think hemorrhage. It needs to be firm. If it's kind of boggy, it's going to allow that placental site to bleed, right? So how do we handle postpartum hemorrhage? What do we do? What's the very first thing we're going to do? We're going to run out and call the doctor? Massage, right. First thing we're going to do is massage. They have standing orders. We don't usually have to call the doctor. Then we can give medicine. Medicine isn't working. I'm not leaving the patient and running out to try to call the doctor on the golf course because my patient could bleed to death. So I'm going to have somebody stay there, continue to massage, and continue to give them medicine that will keep it clamped down, and then they'll call the doctor. Okay? So think about how you're going to handle this, what the steps are that you do. Also, if I have someone in pain or has edema, especially in the perineum area, what are the things that I can do for them? And is there a time frame that I can do them? So say I have someone who has a second degree laceration and they're all swollen in the perineum area, and what are some of the things I can do to get the edema down, to help with the pain and stuff like that? What are some of the things that I can do that aren't necessarily just like Motrin or or some Tux? Yeah, I could use Tux. Ice packs are great. They're going to decrease. What's some of the other things? This is in the first 24 hours. Is there anything that I can do after the 24 hours that might help heal that area? There's one of the things that we usually do, but you usually can't do it for 24 hours. Can you remember what it is? Sitz baths, right. First 24 hours, it's going to be cold, okay? Then we're going to go to the heat. We don't want to put heat on there for the first 24 hours because the heat would bring in more edema. So that's why we don't do sitz baths, which is sitting in nice warm water or having warm water sprayed up on you and circulating around in that area. That's done after the 24 hours. So remember that. There are things that we can do in the first 24 hours and things that we can do after. Okay. Beta strep. What is beta strep and what do we do first? So from talking with Natasha that the beta strep, if mom comes in with a positive beta strep, what are we going to do for her if she's in labor? Oh, yeah, we're going to give her antibiotics. What happens if she comes in and she's what we call a stop and drop? And we didn't get any antibiotics in them. What are we worried about? Are we worried about mom? Hey, it's going to be more likely an infection in the baby as opposed to the mom. Okay. A lot of times beta strep is kind of like a normal thing that some women have down there, but it is not very kind to that baby when it's passing through the canal. Okay. So let's go on with babies. So we're going to talk about newborns and newborn complications. They're kind of all mixed up in there. So think about what kinds of things on premature infants, what are risks? What's one of the biggest risks that we have with them? Can you guys think? What are the biggest risks? This is a preemie. And a preemie is under 37 weeks. Lungs, yeah. So lungs not being developed. What else are they at high risk for? Your post-term and your LGA babies also have this big problem. Hypoglycemia, right. And they are at higher risk for jaundice. But first, always think, if they're breathing okay, ABCs, if they're breathing okay, go with hypoglycemia, okay? Because that's the first thing you're going to test them and make sure, because they're notorious for being low. The preemies are, okay? Also, for SIDS, or sudden infant death syndrome, what are some of the things that we can do to help put our kids at a lower risk for that? What are some of the things that you've been taught? Baby on their back, right? Sleeping position. Binkies, correct. Okay. Nothing in the crib with them, right? No bumpers, No of those other things like that. Yeah, so they can't get their mouth or the face up against anything. Right. Okay, so think about some of those preventions. You will need to know, what is the difference between pathological jaundice and physiological jaundice? And which is the worst? You guys know? Any takers? All babies will get jaundice, but which kind are they going to get? Which one is before 24 hours? Which jaundice is going to be the bad one? Okay, so you have your pathological. Pathological sounds bad. Okay, so it's going to be in the first 24 hours. It rapidly goes up, and the baby's usually at least a 12.9 on a term baby. Okay, normal physiological jaundice is caused because we break down red blood cells, and it's slow and methodical. And it usually doesn't peak until 3 to 5 days on both of them. But it doesn't usually go up too high. Okay? So the physiological is the kind that all the kids are going to get. If it's too quick and too fast and too rapid within the first 24 hours, you're going to be looking at pathological. Pathological is usually caused from some kind of an issue. A lot of times, ABO incompatibility with the mom, okay? Or some kind of isoimmunization with the mom, with the Rh factor and things, or some other kind of issue. Babies, bilirubins will go up if they have immature livers, which they all do. And that's the reason why preemies are worse, is because their livers are even smaller and more immature. And they're breaking down all those red blood cells. You will have higher risk on your jaundice kids if they have any extra blood that they have to break down and get rid of and replace with the normal blood we have, okay? Here we go, because I told you on these congenital abnormalities, you need to know what those are. They are in the complicated newborn. Make sure you know what they are and what they mean. So what is the different types of things? What's a cleft lip? What's a cleft palate? What's an oophoceal? How about the cardiac ones, the different types of cardiacs? Make sure you just know what those are. You don't have to really know cares. You just have to be able to identify them. Spina bifida, what does that really mean? So when you're looking at the test, what it's going to have, it's going to describe something, and you're going to have to pick which one it is. Okay. Also, if we're looking at interdisciplinary teams, there's that word on your little list. That means what team works on that baby or that adult. So say you're in a med-surg area, who are the people that come to the meeting to talk? So you've got usually you've got the doctor, you got the nurse, you got a nutritionalist, those kinds of things that are all going to be working towards that person getting better. Social services, those kinds of things, okay? So think of, what groups do I want to get together to discuss this case in order to make them better holistically, okay? That's what the interdisciplinary team is. Remember about how does parental attachment work? And then also bonding, make sure that you're very aware of what bonding signs. What do we look for in mom and dad? What do we look for in the baby if they're bonding? Okay. Also, what is surfactant and how does it play? What's it part with the lungs? How does that work? What is it and what does it really do? And when is there less of it? And why do we need to be worried about it? Because then you're going to get into where you have respiratory distress syndrome because they don't have enough surfactant. Okay. And I think that's all I've got until I get to sex. So it's now Natasha's turn, if she is still there.
Yep, I'm here. All right. Okay, let's move on to growth and development. I'm just going to hit on some key things to pay attention to on these charts. So if you have it handy, just highlight it or just make a note, because that will help us to go through this very quickly. So just remember that at 4 months, we expect that the baby can start babbling at somewhere between 3 to 6 months. And also stranger anxiety can start as early as 8 months. Moving on to the next chart. Remember that toddlers engage in parallel play, and we expect them to understand object permanence somewhere between 12 and 15 months of age. That's where, and you can, I'm not going to define object permanence. I'll just wait for somebody to type that into the chat box. And that's it for toddler. Moving on to preschooler. Let's see, just remember that preschoolers, remember they are engaged in pre-operational thought, where they believe in magical thinking, and they have pretend playmates, that sort of thing. I'm looking for my cursor. Okay, next slide. So at about 6 is when they may start losing their baby teeth and the deciduous teeth. And this age, early school age, they thrive on praise and recognition. They love they love the phrase, watch me. They like you to watch them while they're doing their cool stuff. They like having an audience. We'll talk more about some of the issues in just a minute, but just looking at slides, the tables, what I'm going to call attention to for adolescent is that they engage in risk-taking behavior. That's part of their neurologic immaturity of their neurologic development. And the prefrontal cortex of the brain is not fully myelinated, so they don't have a lot of good judgment. So, and they feel invincible and things like that. And okay, so now we're ready to talk more about the issues. So, which I've got on the next slide. Got to get it up on mine so I can read it. Okay, so know the difference between growth and development. I noticed nobody typed in the chat box what object permanence is, so I'm guessing you guys already know that. If you don't, look it up in your notes and you'll find it there. Just that, but it's important to remember what object permanence is. Let's see, for development is the progressive acquisition of skills and capacity to function. Car seat safety. We just remember that the car seat needs to be installed correctly and in the safest place in the car, which would be in the back seat. Definitely no children in front, no car seats or children in front of an airbag. We do recommend that all the way up through age 13, that it's preferred for children to ride in the back seat because it is safer. As far as the harness on the car seat, it needs to be secure, snug, so it needs to be just right over across the chest. So it needs to, the parents need to know to make sure it's not too loose, not too low, not too high. They need to remain rear facing until they meet the weight limitation of the rear facing car seat. And sometimes parents think that if the feet are pushing against the back seat in a rear facing car seat, that means it's time to turn them around to be forward facing. But don't go by that, because it's perfectly fine if their feet are pushing against the back seat, because they can adapt to that. It's not uncomfortable for them. So just leave them rear facing until they meet the weight requirement where they have to advance to a different car seat. Let's see, negativism. That's when the toddler is throwing temper tantrums or saying no. So the reasons why this age group, toddlers are negative like that, is because it helps them to exert their independence a little bit more. Right, Carolyn, rear saving is much safer because if they were to have an impact, it's just safer to be rear facing. In fact, the military airplanes, the seats are facing the rear of the plane in military airplanes, just because it's safer for the, and they're not worried about whether people are bothered by the fact that they're rear facing. Let's see. I was talking about negativism. Toddlers have not yet developed impulse control, so they fall into fits of temper if they don't get their way. They have a limited vocabulary, so they have a hard time communicating their needs. So if the parents don't get what their needs are, they kind of fall apart. And no is a powerful word to them because it helps them to exert their independence, like I said, and it gives them a greater sense of control. And it's more of just their frustration in exerting their individuality. It's not about willful rebellion. Okay, remember the echolalia, where they repeat a word or a phrase? That is normal up through 30 months of age, which is 2.5 years. Any time after that, however, it is considered a sign of autism. Nightmares. They can be night frights are nightmares or night terrors. So nightmares are when they are frightened and they are aware. If the parent comes and comforts them, the parent should be told to go to their bedside instead of, they don't want to ignore the child. They don't want to bring the child into their own bed. So going to the side of the child is the happy medium there. Night terrors are the ones where the child is screaming, but they don't have any remembrance of it. So it's more distressing to the family members than to the child experiencing the night terrors. Functions of school refusal are there's 4 possible functions, and note that this is different than genuine physical illness. So if there is a genuine physical illness, that is not a function of school refusal. That is a legitimate cause for why they should be staying home. The rest of these are things that can be worked with cognitive therapy, cognitive behavioral therapy, to help them to feel safer at school and to enjoy being at school and have a good experience there. So the 4 functions are to avoid negative stimuli, such as they don't want to get called on in class. Avoid social situations such as bullying or being picked on, desiring attention from caregivers, so getting special one-on-one attention from the caregiver while everybody else is gone for the day, and then pursuing positive reinforcement. So if they get to go around with their parent and do fun stuff while they're where should be at school. Okay, let's see. The next one is adolescent. So dating safety. We encourage adolescents to choose to safe dating practices, meaning that they do group dates, or they're around a lot of people that they know and feel comfortable with. They're in areas where they feel safe and they have access to being able to contact people, such as having a cell phone and having a code word where they can send a message quickly and without alerting somebody that they may have developed a reason to be concerned or fearful of, without alerting them that help is on the way. And also, there should be no alcohol with adolescents. There should be no underage drinking, so they should not be drinking. So we encourage that. And as far as discipline goes, discipline for school age and older children needs, especially adolescents, it needs to be consistent. It needs to be explained so that they know what their expectations are. They need to kind of respect the authorities. They're more likely to get adolescent buy-in, and if they feel like they've been heard in making a decision as to what appropriate consequences are. So that's why we encourage the parents to have the adolescent express their views freely and to listen to them. Okay, I think now we're ready for Carolyn again. Yep.
I'm coming.
Okay, good. I know it takes
Little time. Okay. So on human sexuality. So make sure that you know what the sexual response cycle is. That's the thing where how does it work? Does it work different for men than it does for women? What's that refractory period? Is that for both men and women? Think about those things. So the excitement, the plateau, or all those different levels and what has to happen. Okay, so also sexual dysfunction. Specifically, I think you need to know what there's 2 parts on your PowerPoint there. Look and see what's erectile dysfunction, what is premature ejaculation. Make sure you know what they are, what usually cause them, and what do we usually treat them with. And I think that is all that they're going to talk about with sex. I'm sorry, guys. I know you knew so much more, but anyway. So now it is back to Natasha.
all right. So Carolyn, if you want to drop off of this, I guess, and I am happy to have you had any input, but
okay. Well, if there's anything anybody needs from me or doesn't understand about the list, which pertains to the areas that I taught, I'm very open to you texting me, and I will answer whatever I can. Okay. So good luck, guys, and love y'all. I know you can do it. We're going to all get 90s, if not 100. Correct?
Yes.
We'll see ya.
Thanks, Carolyn. Okay, so now let's talk about STIs. Again, I'm just kind of call attention to the things that we need to focus on for the final. Know the difference between the ulcers that you see in syphilis versus herpes. So the two types of STIs that have ulcers are syphilis and herpes. So what's the different distinguishing factor between those two lesions? Does anybody remember? Type in the chat box. Right, whether or not there's pain. So which one is painful? Good, herpes. And syphilis it does not have any pain. It's painless. Great. Which is the causative agent that is most likely to have caused PID? So when a woman's diagnosed with pelvic inflammatory disease or PID, we assume that it's going to be caused by, like 90% of the time, it's usually caused by one of these causative agents, and it's not herpes. It's a bacterial one. It's not a viral one. Right. It's usually caused by chlamydia, gonorrhea, and well, we won't talk about the other one that's not on the list, but gonorrhea can also cause PID, but it's not near as common as chlamydia is. So when PID is diagnosed, the provider goes straight to giving antibiotics. And the antibiotics that we would choose are antibiotics that are appropriate for to treat, that are effective with chlamydia. So that's going to be your doxycycline or azithromycin. And also remember, why do we give, if there is gonorrhea, do you guys remember why we give ceftriaxone plus azithromycin? I don't see anybody jumping onto the chat box. Oh, there's Maddie. Let's see what she's going to say. Right. It's because gonorrhea is resistant to all antibiotics except for third-generation cephalosporins. So that's, and ceftriaxone is a third-generation cephalosporin, and it we give it with azithromycin to augment it to help decrease further development of resistance. Let's see. I'm sure you guys remember this, but if a woman comes into a pregnant woman comes to the labor and delivery unit and she has active herpes lesions, how are we going to deliver her? Right, always by C-section, so that we do not expose the infant to the herpes, which could cause a systemic infection in a newborn. And then what is the major cause, which of these is the major cause of many cancers, including cervical, penile, oropharyngeal? Right, HPV. All right, that's it for that chart, but what's not on the chart, but what I'm going to add, this is from your the STI PowerPoint, are the nursing implications. So remember that that whoever's being treated for an STI, they need to be educated to inform any partners, sexual partners they've had in the last 2 months, to let them know that they've been exposed to, possibly exposed to that STI, so that they can also be treated. If they don't want to be the one to personally contact their previous partners, they can give the information to the health department, and the health department will contact them. But just to keep it simple, notify sexual partners from the last 2 months, and also they need to be treated at the same time. Otherwise, if they treat run and they get better, then the other person, they'll just keep reinfecting each other. And so they have to be treated at the same time, which is why most states have a partner, an expedited partner therapy treatment. Okay, so let's move on to the reproductive table. And we'll just go through this very quickly because we're just going to focus on the key things for the final. Remember that the cystocele, the symptom that we look for with the cystocele is a bulge in the anterior portion of the vagina. That's because the bladder is prolapsing into the vagina and the bladder is anterior to the vagina, so that's why we feel it in the anterior wall. We already talked about herpes being a cause for cervical cancer. Not herpes. Oh, sorry, HPV, human papillomavirus. I did not just say that. Anything else than HPV caused cervical cancer.
Attention. If you are parked in the lower
Okay. Let's see. So the next one is that we're going to look at is PMS, PMDD dietary methods of minimizing symptoms are to avoid consuming things like refined sugar, caffeine, alcohol, and a lot of salt, and to consume whole grain,
in the lower
whole grains, lean proteins.
lot closest to student services.
They're getting ready for the pinning tonight.
To move your vehicle immediately.
And guess what? I did not park there, so I don't need to run off and move it.
Closest to student services, please.
Okay, and menopause, remember that perimenopausal women need to be instructed to continue using birth control even when their periods get become irregular during that perimenopausal stage, because they could still conceive in perimenopause. And benign prostatic hyperplasia, symptoms of that are slow and complete bladder emptying, urgency, frequency, difficulty starting a stream, and dribbling. I was anticipating the word dribbling and changed stream to dream. We screen by watchful waiting, just watching for signs and symptoms to worsen to the point where it's intolerable for them, and so they want to have surgical repair or to remove the part of the prostate gland to allow for easier bladder emptying. And then low testosterone, we're just going to look at this. Once diagnosis is made that there's a low testosterone level and the man is started on testosterone treatment therapy, they only need to check his testosterone levels about once every 6 to 12 months. So he doesn't need to have his level tested for every dosage, and it's administered generally through a gel or a patch, but it can be given IM or sub-Q, and in some cases even orally. But usually it's given as a patch, and the patch is recommended that they place it where it can't be touched by other people, especially family members. All right. Talking about birth control is the cervical cap, diaphragm, they need to be used in conjunction with spermicides. Okay, now we're ready to talk about early and middle adulthood. And guess what? There's a lot. There are a lot of questions on these last two units because this is a comprehensive exam, but you did not get an exam covering the early adulthood and middle adulthood units. So there's about 11 questions for each of these two units. So about 22 of the exam questions. So almost a quarter of the exam is on these two units. So memorize this information. This is a table that I have, and you can find it on Canvas under 1040 module page under, I think it's unit 20. If it's not under unit 20, it's under unit 19. Go ahead and just study this really well. Almost all of this information is going to be on the test. This is kind of like your very concise study guide. So let's go over this. Developmental milestones for early adolescents are choosing and establishing a career, childbearing, starting their own household, and expanding social circles. Physiological changes, the blood pressure continues to increase because the blood vessels are less elastic. The basal metabolic rate decreases, but the appetite stays about the same. So there's a tendency for people to gain weight because they feel like they still want to eat the same amount even though their metabolic rate has decreased. So, and people begin to lose their hearing frequency, their high frequency hearing, even as early as their early adulthood. Erickson's stage is intimacy versus isolation. So intimacy means that they are in a loving, supportive relationship, and isolation would be if they are choosing not to be in a relationship. That's not to say that it's wrong to be single. It's just saying that according to Erickson, it's not as fulfilling. You would want to have the intimacy to be fulfilled psychosocially. And then for the Piaget, well, its post-formal operation continues. Don't worry too much about Piaget because is not as applicable for this age for adults. Nutrition, we encourage people to eat a diet low in saturated fat and avoid trans fats. So the healthy fats are olive oil, nuts, fish, avocados. Eggs are a healthy food, despite what your textbook says. And just know what the difference between the healthy fats and the unhealthy ones. So the unhealthy ones are generally things that are solid at room temperature, such as butter, coconut oil. Limit added sugars and artificial sweeteners. Drink healthy beverages. Water's the best. Eat a wide variety of nutrient-dense foods, not calorie-dense. Let's see, issues are safety. They're responsible for not only their own safety, but the safety of any children that they might have. They need to know to wear protective gear where applicable, such as goggles if they're going to be working with things that could expose their eyes, helmets. Fire safety includes smoke detectors, fire extinguisher, an escape plan, and storing flammables appropriately. Mental health. Stress causes health problems, not just mental health problems, but it can also cause physical health problems. Stressors that are common in this age group are work, and work-related education, relationships, concerns about finances or money. So we teach to deal with stress by going to its source, addressing the source of the stress and try to alleviate the stressor, and also helping them to say no. They can say no using other relaxation methods such as meditation, humor, coping skills, and spending leisure time or time with friends or pets, exercise. Smoke, secondhand smoke is not good for even adults. And smoke can increase the risk for heart disease and lung cancer, whether it's especially for smokers, but also for secondhand smokers. And health maintenance, exercise to maximize the vital capacity and maintain cardiac output and musculoskeletal and gastrointestinal systems. Resistance training is weight lifting, and that increases bone mineral density and muscle strength. And you can use an app. It is really good to use an app to track your nutrients, your exercise, and your weight. Sleep 7 to 9 hours a day. Brush and floss teeth to prevent gingivitis, which can progress to periodontitis, which can cause the teeth to fall out. And establish self-regulation. So if somebody, part of mental health is to recognize your strengths and also to learn how to self-regulate so that you can meet your goals and follow through with them. Okay, let's now move on to middle adulthood. I'm trying to hurry through this because my goal was to finish up by 4. We're not going to quite make it, but it won't be too much longer than that. Let's see. They often have new roles with we'll get to that a little later. Erikson's stage for middle adults is generativity versus stagnation. So generativity means they're giving a lot back to their community, whether it's volunteering or being really engaged with their work. A lot of times they are in positions of leadership at this age group. Stagnation is when they're preoccupied with themselves and they're resisting change, and so they're not really contributing to their community or society. Then for nutrition, they need to have increased dietary calcium to help to prevent osteoporosis. We encourage the Mediterranean or DASH diet. They're essentially the same. Let's see. For this age group, after age 50, they should be encouraged to get the Shingrix vaccine if they've had the chickenpox, and that will help them to prevent them from getting shingles. Be aware of these issues. So there can be at risk for empty nest syndrome when their youngest child leaves home or last child leaves home. Sandwich generation if they're caring for both their children in the home as well as their parents, and that can make them feel just really stretched as far as all of the demands. Midlife crisis if they look at their lives and see that they're not where they were hoping to be by that point in their life. Presbyopia, remember that's where they lose their near vision, so they have to hold things at a distance to see them, and you assess for it by handing them a sheet of paper and asking them to read it, and you watch to see if they have to hold it up close to see it, or if they've got presbyopia, if they hold it at arm's length to read it. Cataracts or the cloudy lenses, which can cause the vision to be blurred and cloudy. And glaucoma is increased eye pressure, and so it's checked by, they blow a puff of air into the eye, and if that causes them pain, then that means they have glaucoma. that would be treated with eye drops to adjust the pressure in your eyes. Osteoporosis, there's an increased risk for this, especially in women, postmenopausal women. Know the risk factors. So if you remember the picture that I have on the slide of the woman, so she's petite, she's frail, she's Caucasian, she has a cane, so which indicates she maybe has a previous fracture. All of those things are, and postmenopausal, so age. So all of those things are your biggest risk factors for osteoporosis. And it's treated by medication. Just remember that people need to be treated, need to be instructed to take the medication, follow the instructions for taking the medications to improve absorption, because even under the best of circumstances, very little of the medication is absorbed. So they have to take it appropriately to get a significant absorption. Exercise under health maintenance. We teach people that even in middle age, it's good to exercise. You might want to get a doctor's approval, especially if they've led a sedentary lifestyle. But as long as the doctor gives them an okay, we want them to exercise, and we want them to exercise vigorously, because it does help to keep their cardiovascular system, respiratory system, GI, musculoskeletal, all in optimal condition. We do want to avoid fall risk. Oh, and I should have emphasized that under treatments for osteoporosis. Just going back to osteoporosis, a really important treatment is prevention, which is to prevent fall risk. So just make sure there's no trip hazards in the area for them. Cancer screening, we want to start screening for colon cancer at age 45. Remember that, 45, because that is a recent change. It used to be 50, but now it is 45. At 45, we start assessing for the FIT. That's the fecal test. So they look and see if there's any occult blood or anything in the stool test. So that the FIT test begins at 45, and then they start doing the colonoscopy, and those are routinely done every 10 years. They'll do it more often if they see suspicious findings, but the routine is colonoscopy every 10 years and the FIT test, the fecal test, every 1 year. So keep those straight in your head. Nursing care is motivational interviewing, where, and we talked about this under adolescence, but it's really important for any age group. And motivational interviewing is where you show empathy, you assess the patient's goals and guide them to see any discrepancies between their behaviors and their goals, and ask for their permission to give them information that could help them meet their goals and offer support. And then health coaches are to advocate for patients to take responsibility for their own health, providing resources, identifying risk factors and barriers to healthy living, teaching about prescribed medications, and promoting a healthy lifestyle. And if those, yeah, it looks like they're on there. Okay, I think we're just going to finish up with a little bit more detail on the osteoporosis. I think I've already gone over these, so I'm just going to double check. Yeah, so I went over this already, the risk factors for osteoporosis. I didn't say lifestyle risk factors, which are cigarette smoking, high alcohol and caffeine consumption, and low calcium intake, and sedentary lifestyle. So another way to help prevent osteoporosis along with preventing falls is also weightlifting. And then I already said what I needed to about medications and diet, increase the calcium and vitamin D in the diet, exercise, walking, and weight bearing competition. Okay, yeah, so I covered all of that. All right. I'm ready to let you guys go unless you've got any questions. Does anybody have any questions? I know I went over that last part kind of fast, so if you want to, I really recommend that you just take the time to really peruse that early adulthood and middle adulthood information. That's almost a quarter of the test, and as long as you're familiar with that, you'll do really, really well. This has been a good, concise summary of the things you need to know for concise being an hour and a half, but we're talking about reviewing the whole semester, so hopefully it feels like it's time well spent. Any questions? Hopefully you guys are still hanging in there. Okay. Well, thanks. Those of you who were able to join us, thanks, and thanks for participating in the chat box. And I don't have any sample questions because I knew this was going to be long, just reviewing. So just review this, and I recommend that maybe you watch it one more time, especially if you're, well, yeah. Whatever. I'm going to stop the recording.